Thank you everyone for joining us. My name is Kiro Haroon. I'll be presenting this with Amanda and LA.
Hi.
Hi.
So tonight, again, we thank you guys for coming. The big concept that we want to talk about was peer support. And really kind of this is within the Stop the Stigma EM month, kind of this month of October. And broadly, we want to talk about this idea of before you break, leaning on your colleagues, peer support in emergency medicine. And I'm gonna start with kind of a difficult story. To start a discussion, kind of to start our evening, I wanted to share a patient story that a friend of mine kind of gave me permission to share. He was working in the ER. It was a normal, busy shift, record boarding as usual. He had a young 25-year-old male who came to him. He had a history of HFrEF, he had a history of stenosis, aortic stenosis, that is. He was short of breath and his heart rate was 147. He got an EKG and it was supraventricular tachycardia, SVT. They gave the patient adenosine 6, adenosine 12, and then another 12, and there was no effect. And as they were considering the patient's EKG, they looked at him again and he fell asleep. And his blood pressure went from 120 to 100 to 70, and it was going down very fast. Understandably, they brought in the defibrillator, and the patient's mom was there and turns to my colleague and says, "Hey, are you going to take care of my son?" And my colleague says, "Of course, I promise to take care of your son." They get the consent for a cardioversion, invites her to leave the room. The patient's given etomidate. The defibrillator is set to 200 joules. They synchronize and they cardiovert the patient. And there's a rhythm change. They go from SVT to VTAC. They check a pulse and there's a pulse there. And then that VTAC goes to asystole and the patient loses the pulse. CPR started, epinephrine's given, and they get ROSC. The patient's kind of pulse comes back and they immediately go to the CCU. That night, the patient has multiple PEA arrests, and the family decides, because of the severity of the aortic stenosis and the lack of other interventions kind of able to be given to the patient, that they withdraw care and the patient dies that night. I've talked to my friend a few times about this, and he thinks about that cardioversion, that one cardioversion a lot. Was that the right choice? Was there a right choice? What about that mom he made a promise to? He felt like he broke that promise and he carries that trauma with him a lot. That was a tough story, but that is likely not uncommon for a lot of us. And that's kind of the crux of it, a crux of this conversation, that we go through a lot in emergency medicine. And leaning on each other is kind of pivotal. On that tough note, I want to transition to our learning objectives tonight. I'm a medical educator and I have to have learning objectives. So kind of to guide this conversation, we've got three big goals by the end of the session. One, we want us kind of all to be able to recognize signs of distress in our colleagues. Two, to describe two structured peer support models that could be used elsewhere. And then three, we're going to all be able to apply the 7 basic principles for peer responders. And this is kind of broadly, this is our journey today. We're going to talk about 3 concepts. We're going to talk about 2 solutions. We're going to give that take home, and then we're going to wrap up. So to start, we're going to start with our first concept, this idea of secondary trauma. So the first concept I kind of wanted to bring to our conversation is this idea of secondary trauma. And another term that's been used within the space is this word second victim syndrome. It was initially coined by one Albert Wu at Johns Hopkins. And the idea is it is the emotional and psychological distress experienced by physicians or healthcare professionals in general, really, in an adverse or difficult patient encounter or clinical event. The patient is the first victim. And then the initial conception was this idea that the physician or the provider or the healthcare professional was the second victim. Now we broadly call this just the secondary traumatic stress or secondary traumatic experience. And there's really 6 stages of this concept. And I bring this up because I want us all to think about, when have we experienced these stages and when have we seen it among others? The first one is this chaos and accident response. This is the initial shock, the emotional numbness, the distress that you experience in this space, right? That moves to the intrusive reflections, the idea of replaying the event over and over again. In the workspace, we see people having cognitive overload, hypervigilance, even maladaptive coping. From there, there's sometimes this pursuit of restoring personal integrity, but there's a struggle with self-worth. In the clinical space, people start to be more defensive in their medicine because they're worried about litigation, right? They're trying to restore their own belief in their ability to practice medicine. Stage 4 is this interesting kind of phrasing, enduring the Inquisition. The idea here is just facing the external scrutiny. Maybe there's formal investigations. Maybe there's an M&M that was made in good faith, but it triggers the emotions of the first event. From there, some people are able to obtain emotional first aid. They're able to seek or receive it if the resources exist, right? Peer support programs, structured debriefings, psychological counseling, or mentorship. If the resources exist, some people can hit this fifth stage of obtaining emotional first aid. And then finally, everyone moves on. The question is, move on to what? Some people move on to growth, to survival. Others will move on to leaving medicine. And then the whole topic of this entire month, Stop the Stigma in EM, some people move on by deciding to take their lives, right? These are the broad 6 stages that I want to kind of introduce. And from here, I wanted to kind of open this space up to everyone here. I want you guys to think about a time when you or a colleague seemed trapped in stages 2 through 4. How was that experience? And what might have helped them move towards some level of stage 5, emotional first aid?
I personally have gone through several of this, and I still do when I get those letters asking me about the case. It's one of those feelings where, yes, there's the vicarious trauma, the initial interaction when we're resuscitating, but then there's also the having to prove yourself, especially when they're reviewing the case, and the emotions before, even like for me, as I'm driving home, as I'm like ruminating about the different things that happened, the shoulda, coulda, woulda, and then getting to a point of, okay, I'm kind of comfortable with what I've done, or even talking to friends or talking to colleagues. I do that a lot as well. And then when you get that email, and it's never the ones that you expect it to be, but once you do, you're like, huh, it's a secure email. I don't know what it's about. And then you read it. And like you said, Kira, it's well-meaning. It's really just about, in our department, in our institution, we don't call it peer review, it's case review. So it's about the case, not the peer. But it still feels like I'm the peer that's being reviewed here. And it brings back memories of when we would do M&M and standing in front of folks, having to defend our cases. I trained in the East Coast. That was a very common thing. We don't do that anymore, at least at our shop. We don't do it that way. But M&M still exists, right? Still, like, it is, whether you can have a system that is super supportive, I still get nervous. And actually, it's because I care. If I didn't care, then I would not dread about those emails. Amanda, what do
Yeah.
you think?
Yeah, I was going to say, I think you bring up such a great point because, one, some of these stages can last so long, right? You've built this perfectly to show what the stages are, but I think, when one of these cases hit me this past year, I was shocked with how long I was having all these intrusive thoughts, which was, of course, making it so I couldn't sleep. So I'd go back to shift even more hypervigilant and worried and just felt destroyed, like personally. And, all we're here and we all care about well-being. And it felt even worse and like more negative that as a well-being leader, I couldn't get past some of these things. And I
Mm.
remember coming to LA when we were both at a national conference. And finally, that was, I feel like, finally getting myself that first aid was emotional first aid was talking to LA. And even though I talked to other people and they were trying to be reassuring and help me and get through the stages, it was finally like being there and facing it elsewhere, maybe not around my own city or emergency department, that really struck that chord to move on for me. But it's so hard. And so I think all of these things, whether it's the email or I don't know if you guys get this a lot of, I heard about your case the other day. Oh, those ones, even though people are so well intentioned, right, of like being with you on how bad it must have been, it just sets you back a few steps each time. So I think even acknowledging how these stages really feel and the time it could sit around still and knowing just talking and finding that right person maybe to get you there or the right support is so important and to not stop trying, even though sometimes it feels like you keep going through these loops.
Yeah.
I can imagine also, I think there's the aspect of it that, yes, there's the rumination and the shoulda, coulda, woulda, but there's also our immediate reaction, our response in the emergency department because we're very tight. That's just the community that we work in. We vent a lot and we talk to each other, right? Hey, let me tell you about this case. And which is great because it allows us to intellectualize a little bit, but actually it does not help us move past it other than maybe convincing each other that like what I did was right. But it's never really getting to that point of validation that I'm learning. But one thing is definitely helpful there is that it's helpful to talk to somebody who's gone through it similar to what you've had before, or have who can at least relate to what it feels like, at least as a doctor, hearing from another physician that like, yeah, I that happened to me too, because then it feels less lonely when I go through that.
Yes, the normalizing it is so huge.
Yeah, these are such incredible points. Thank you guys so much for engaging. LA said in the chat, everyone feel free to kind of get engaged with we have a few more discussion questions. I appreciate this discussion so much. Yeah. A second concept we want to talk about now is not to kind of focus on all of the negatives, but we want to kind of start with the different things that we've gone through that we've always gone to each other at least for support. The second concept is this idea of imposter phenomenon, and then the Stanford Duck Syndrome. These are kind of two things that are very close to each other, but the idea is secondary trauma, it leads to chronic self-doubt, right? We just kind of Amanda and Ellie just talked about how we gotta go back and forth months and months at a time, and it builds into this first concept of imposter phenomenon, which we're all very familiar with. This persistent self-doubt, this internalized fear of being exposed, this idea of I want to talk about this, but I also don't want anybody else to find out that I actually wasn't exactly sure what I was doing, or maybe I was sure what I was doing, but I don't know if I'm as good as the people around me. And the Stanford Duck Syndrome adds to that of this external composure above the water. You want to look like success, right? You want to kind of have that strong face, but below the water, you're struggling, right? You're paddling as quickly as possible. And these two things together, I like to say they create the perfect storm, right? They create this cognitive loop, rather, of I just got lucky. Others are more capable. I don't deserve to be here. And it kind of creates this idea of externally, I'm going to be fine, but internally, again, I shouldn't be here. And it really pushes us away from a space of vulnerability where we can talk to each other. Having introduced these concepts kind of in this space, I want to open it up back up. I want to hear from you guys one more time. Think of your own journeys. I'm sure I am not the only one experiencing these two things. Where have you felt not enough? And have you worked through the imposterism or maybe helped somebody else work through the imposterism?
I can start with this one. I feel like almost daily still there's times where I think I'm not enough and know that I am in that imposter syndrome. And I have learned to deal with that, of understanding that maybe that's part of emergency medicine at times for me too, is I know all the things that there's constantly to know. And I do have those self-doubts, but I'm going to keep working towards it. So I don't know if I've always worked through it, but I also acknowledge that I know that's what it is. And that's not necessarily fair of me, but I do feel like I feel it frequently.
Well, I think what you're getting at, Amanda, is that there's a study actually that Tate and team published that physicians have the highest imposterism in the United States compared to any other workforce. So I put the link in the chat because, I mean, by simply being a doctor, just showing up to the hospital, we're more likely to feel like we don't belong there than anybody else that shows up there. And so that's just, and so far, by the way, I want to acknowledge that we've been talking about a challenging case, right? And a lot of the things that impact us is not just the challenging case. I love how Kiro is utilizing this like perfect storm where you have the imposter, the Stanford Duck phenomenon, and there's the vicarious trauma. And by the way, from a peer support perspective, full disclosure, I run the peer support program at Stanford. And so what you're doing, Kiro, is actually essentially what we would normally do, which is you first normalize, acknowledge a lot of these things because these are common human experiences. Anybody in our situation would feel like this. And that's part of self-compassion, which is really for me what is needed for me to overcome that imposterism. It doesn't go away easily. In fact, some people just kind of tame it and acknowledge that it's there. And also we know that that's why it's a lot more common during times of transition. So when you attending, when you become a third year resident, when you become a third year medical student and you're going through the clerkships, like those are the times when you're all of a sudden like, huh, I don't know how I got here. I know I did a test and I know I passed them. I did very well. In fact, we were selected specifically to get to this point. And yet, because of the way that we select for doctors, it's easy to then all of a sudden second guess ourselves that maybe that I just got a pass here, or I somehow slipped through the cracks and I would never have gotten in if they had known. But the reality is that we are deserving of being there. I am deserving of being here. But I guarantee you, like, I will be the first one to acknowledge that, like, when it hits me really bad. I'll share this story of, and I got permission from a colleague because he announced it in our faculty meeting just last week. There was a patient that came in respiratory distress, stridor, airway edema, and that person was texting me along the way that I'm sorry we're adding more work to you, but like I'm getting really worse as they're driving. And so you can imagine that somebody is a faculty who's like driving to the hospital, letting me know that like he's gonna be about to be one of my patients. And you know what? Like we actually did wonderful. Like I got ENT to be there. We were ready. We took care of him. Like he had pictures of his epiglottis and supraglottic area. But at the end of it, and he's like clearly he's like sharing this in our faculty meeting. He's sharing this to different people, like ENT attendings, like those groups. But you know what? When I saw him, the one thing, and I'm feeling this, the one thing that I could think of was I tried to put an IV on him and it blew. And of all the things that I can do and I'm very comfortable with doing is putting an IV. And I was stuck on that. And like he gave me a hug. It's like, dude, you saved my life. Like I'm telling the world that you saved my life. And here I am, like part of this imposterism is not just to like question ourselves that we belong there, but actually not having the ability to take the credit when credit is very much well due. And I think that's important for us to acknowledge because, like I said, we've so far focused on challenging cases, but it can also be like, I'm just having a bad day, or like I'm having trouble at home, or whatever else stressors that we're dealing with. And that's not even usually part of the equation because we don't talk about that until something else that is familiar, like a tough case, comes in. And then now we have somewhat of an in to have that conversation. And so I think it's just important to highlight, especially in the context of the Stop the Stigma month, that these things exist, this thing happens, whether we talk about it or not, and that talking about it actually gives us a way out and a way forward to dealing with things.
I completely agree. Yeah. The stopping on the negative thing, the IV, I feel like that's like every other case for me. It's like the one thing. And talking to our resident physicians and our learners, it's so hard where I was giving feedback last night at 11 p.m. and I gave all the positive feedback. And then my resident says, okay, but what do I have to fix?
Right.
I've just spoken for like 5 minutes how you were one of the best second year residents I've worked with in months to a year, and now you're just waiting for the hammer to drop.
Right, right.
We put this in them so early, and
Or is that duck phenomenon, right? Like, and that's why I think acknowledging that exists is important because otherwise all we see are people like getting awards, getting published, moving up, doing all these wonderful things. But I think unless we also stop and share the vulnerability that you were referring to, Kiro, then it becomes so much more impossible to attain. When in reality, like I have a lot of failures, and many of them now I consider intelligent failures because I need that to learn to get to where I am now. But I call it that way, then it weighs heavier.
yeah,
I
I
think
totally agree. Go ahead, Amanda.
my last thing I think you both reminded me of is, and I agree, like the self-compassion does help me like stay constantly like okay with where I am. But watching my trainees that I'm teaching, watching their moments of self-doubt and that fear and what could I have done better in a critical case, I think is really what snaps me out of this because then I
Mm,
am trying to be like, but we did this and we got them this thing they needed and they're going to the next level of care they need. Like and helping reframe it for them and watching someone maybe be in a worse spot than, and now being in that new level of we're there to help them too is really fascinating to watch, to be like, oh, okay, I don't want them to feel what I know that feeling is. And I maybe can't stop it, but I can try to help them go through the steps to start practicing some self-compassion now to themselves of they actually did so much better than they think. Did an amazingly job, like, right? Like people are doing amazing things, our colleagues. And I think LA, you're calling that out is so right. We just don't accept the positives that we have done often because we remember those negatives so easily.
What's coming up for me as well, I think, in this theme of imposterism is that number one, it's a very common thing that happens to all of us, and that we don't really make space to talk about it. And most importantly, that even though I teach self-compassion, I do a lot of projects in self-compassion, that even I'm guilty of not having that same compassion that easily I would give other people, which means that it's a practice that we have to continue to cultivate and refine. And rather than just saying, like, I have self-compassion and I'm immune to this, because it's not actually, it is an ongoing efforts that we have to do so that we can continue to find meaning in the work that we're doing.
Absolutely. Absolutely. And you brought up earlier, there's like so much that's going on inside, but then there's always these small things outside as well that we don't kind of speak to, which brings to mind this kind of third concept that we wanted to talk about, which is this idea of the resilient zone. This is a model that's heavily used within our internal Johns Hopkins kind of RISE or peer support program, but it comes from this trauma resource model. The idea is that like everyone has a resilient zone, right? They can be pushed up, they can be pushed down within the zone, but then traumatic events inside the hospital or outside the hospital can knock you out of that resilient zone. And this is where kind of we find people in these hyper arousal states or hypoarousal states. And I think this was a big learning point for me as I've been trying to help people through levels of imposterism, kind of this duck syndrome, and all the levels of secondary stress that sometimes my colleagues or my learners can be hyperactive, anxious, angry, but then also sometimes they can just be disconnected, exhausted, or numb. And these different sides of kind of being broken out of the resilient zone are things that I look for in myself, I look for among others, but also kind of I talk to a lot of my teammates about keeping an eye for, because people will kind of pop out of this resilient zone in
I
different
think
ways rather.
I really like this. It reminds me of the polyvagal theory, so that it just is pretty much like highlighting when you're hyperactivated or you're hypoactivated. And what is helpful is that, as you mentioned, that self-awareness. Are you one of those that, like, when you get stressed, do you get hyperactivated and you start like doing so many different things? Or are you one of those that you actually like do the freeze and just stay there, right? So you're either the fight or flight, or you're freeze and I forgot the term. That'll come to me. But
I'm losing it too. I'm losing it. I can't remember.
yeah. But I think what's helpful is from that self-compassion perspective,
Mhm.
one key aspect of it is that training of self-awareness. It's not easy actually to be self-aware. Many of us may not have realized that, like, when we get nervous, we speak faster, or when we get nervous, we start losing words because you are trying to make connections so quickly. That's totally me. But knowing that, like, then you can equip yourself better so that, like, you can anticipate that we know that this is going to happen whenever we're stressed. And so at least knowing that, like, okay, so whenever I get hypoactivated and I'm in that like resting and kind of just slowing things down, I need to start shaking my hands. I need to start like moving around to wake myself up. Or the opposite, if I'm like really hyperactivated and I'm about to like go into another patient's room, I probably should go for a walk first and like do some breathing exercises to slow down my heart rate. But whatever that is, I love that notion of we need to be aware of what others' reactions are. But I can tell you from a peer support perspective, they might be so hyper aroused that like calling that out is gonna make them feel even worse. And so finding ways, and I know you're going to go over this, like what are ways for us to check in with each other is going to be much more important, rather than giving them the like, hey, I see you're hyperactivated. Why don't you do some box breathing? Because probably that's not going to work, even though I do that all the time.
Absolutely. Yeah, along those lines, let's dive into kind of some of the solutions. This is not exhaustive, but some of the things that we wanted to discuss. We've talked about these three concepts: second victim syndrome or secondary traumatic stress or secondary vicarious trauma, imposter phenomenon and Stanford Duck syndrome, the resilience zone, Now, two things that we want to talk about is this night of reflection that we do here at Johns Hopkins, and then this peer support training program that we've been using with our residents as well. So first, this night of reflection. The idea here was to create a trauma-informed evening where residents, fellows, and faculty could come together, disconnect from the clinical space, and reconnect their sense of meaning within medicine, talking about the most difficult cases, but also kind of their day-to-day with everyone from our medical director down to our PGY1 resident, kind of finding a level of human connection. And we organized it in kind of a unique way. This is kind of how we broke it down. We meet twice a year at a faculty home. Our department has actually supported us with some money to bring food into that space as well. And we start with some health humanities experts that give us kind of a narrative medicine piece to externalize some of our reflection. We actually just go to Annals of Emergency Medicine that has a lot of beautiful narrative pieces, and we kind of bring it into that space to allow everyone to reflect on a piece. And then we break it into small groups, everyone from interns to, again, I brought up one of the vice chairs is an emergency medicine doctor. He's roomed into a small group with a range of residents and faculty, and they all have kind of guided discussions. Things like discuss a difficult case you've kind of dealt with, a patient loss, moral injury or moral hazard, chronic distress. Talk about these things and talk about how you've worked through them. And again, everyone from junior residents up to senior faculty are in these small groups. Then we actually, in these spaces, we have a trained psychologist who joins us from the institution, guide us through a mindfulness exercise because the small groups can sometimes be activating. We kind of bring it back down into a mindful space, and then we debrief as a large group. In a large group, we come together, bring kind of big messages that have kind of occurred in the small groups, and we take up some coping strategies as a team. This last year, we did or this last session in June, everyone kind of talked about what is their take home kind of jewel that anchors them and slows them down. And I learned that our vice chair of research swims in the open water 3 miles at a time. This is the vice chair of educate or research at Johns Hopkins. He's a pretty senior individual, and his cardiovascular health is incredible. And all of the residents found this new level of connection with somebody who felt so distant. But we brought that together. And the feedback for the night of reflection, thankfully, has been amazing. 100% of our participants feel like they're in a safe space. They consistently want to attend another event. And I felt like the qualitative kind of things that we got from our residents and faculty was amazing. People loved modeling vulnerability, loved the ability to just allow their emotions to sit. The idea of being a human, although expected, was unique in this space. And then this idea of normalizing shared emotional challenges was such like a beautiful, consistent message here. I wanted to open up to kind of the room. I know we're not unique necessarily. What are other forums of kind of connection that different people have had? I want to hear from you guys. Yeah.
Amanda, I know that you were looking into some of the evidence of like intern year is one of the tougher times. Can you elaborate a little bit more on that?
Yeah, I love that you do this. It's giving me so many ideas of different ways to work with this. But LA brings up a really strong point of we know that there's this critical period of time, specifically in that first part of the academic year, that our interns are at higher risk of contemplating suicide. And it's pretty drastic, the numbers of the increased depressive thoughts and thoughts. I think it's almost like 137 times more that they're thinking of suicide than they previously have. And so I think events like this are so helpful. And even in our institution, we created storytelling during resident conferences, partially to partner with GME to show that they cared and want to help with well-being. And we just did where we kicked everyone out except the two faculty supervisors for this. And we did a storytelling event with just the residents to create safety for them of all the different things they're feeling to help normalize their emotions. Because, yeah, Kiro, you like have it like spot on. They can't, some of them never could imagine that other people have gone through these cases. So hearing the senior residents and the resident just above them or their colleague that was on the rotation before them share similar emotions is really empowering watching them all go through this and get through the sometimes darker emotions to sillier stories that make them all laugh together again. But I think there's just such huge opportunities to do these. And we had, particularly in our shop, had done this in that critical period that we wanted to help interns recognize that they don't have to be alone in what they're feeling, but everyone. But we were like, let's try to start this at the beginning of the academic year to really make this, they understand we want to hear emotions. We want to be there to support them early on in their humanity as a doctor.
I'll add that already, Kiro, you were telling us about imposterism and how that usually happens during transitions. And here, I think what stood out for me is that the interns feeling like they can actually see their seniors modeling the vulnerability. As Amanda pointed out, like those times are very critical for them, especially during their transitions. What's also helpful, I think, to recognize, and I'm curious if you do this during these events, is that we are terrible with naming our emotions. Like I can probably name only like I'm sad, disappointed, frustrated, or angry, right? But if you actually look at the wheel of emotion, there's a lot more things that like we can use. And again, like being able to tap into those different emotions can in and of itself be empowering. And also, again, it just normalizes that number one, we're not as good with our emotions. We don't really train for that as in medical school. And as attendings, I remember another thing that came up for me as you both were highlighting these feedback is that I was really dreading when I was when I graduated from residency, and I was like, I don't know what I'm going to teach the residents. And my favorite attending told me, just be that attending or senior resident you wish you had when you were an intern. It's a very powerful thing she gave me. But in reflection of this, it's really more of I can imagine an intern going through imposterism, going through a lot of the changes, and maybe even being involved in a case that was really challenging with a terrible outcome or unintended outcome, and they're blaming themselves. Or they get a letter from one of our case review folks asking them to elaborate on what they were doing, and they feel so alone. And applying what my mentor told me, like just be that attending that you wish you had, I'm able to say that like through like my career has actually taken off talking a lot about my mistakes. Like my very first grand rounds was rookie mistakes, things I did after, like I learned after residency. So like real mistakes that happened that have real patient consequences. And yet, if I don't talk about it, I know that like somebody else are probably gonna make the same mistake because again, these are just things that are often not discussed. And at the same time, it allows me to honor the patients that were involved because that's all I can do now, right? I can't replace what happened, but I can at least teach other people what I've learned in those cases. And we experience that a lot day in, day out in our practice.
Absolutely. I was pleasantly surprised how open a lot of our senior faculty were and kind of communicating very vulnerably. And I don't take that for granted. I think that is something that needs to be built, that trust needs to be built. And I think a part of it, I underestimated the impact of the health humanities start of it. You brought up LA of like having trouble communicating emotions. I sometimes think of it as like the ice needs to be broken. And when you're able to externalize your emotions, let's reflect on this written short story about somebody who went through a hard experience. We
Yeah.
can talk about that experience, not necessarily my experience, and then the transition into now that I've been kind of loosening up my emotional muscles, now I can start reflecting on my own without kind of being triggered or locking in. I think that was a very key point for us. And having a trained psychologist there, I think there's always a balance of like having a protected space with an outsider. But we had a psychologist, we have an office of clinician and faculty care who kind of look at a lot of the faculty and providers, and they entered this space and they said exactly what you said of, so what I'm hearing is the emotion of frustration, or they're able to kind of name some of the emotions that were floating in the conversation. And it
Yeah.
really was enlightening for a lot of people.
Yeah. And I think I love also the intentionality that not everybody will receive this the way that you intended it to be. And so thinking of will somebody need support afterwards and making it like a lot more accessible for them. Because then it's once they do that, they're like, oh, I did this, I just got support and I'm still here. Like I didn't just like evaporate all of a sudden, or somebody didn't just zap me because I talked to a psychologist or a therapist or somebody, right? Like, and I think that's the goal to kind of just make that activation energy a lot less.
I love that. Lowering that threshold is so huge.
Along those lines, we were kind of hitting a wall within Hopkins regarding kind of this threshold to reach out for help within one specific area, which was interestingly our institutional peer support system. More and more institutions I hear are developing their institutional resources around this, their peer support programs. At Johns Hopkins, it's called the RISE program, or the Resilience in Stressful Events program. This is an institutional peer responder network across the hospital for people to call and reach out to connect for emotional first aid. The issue we found was that our residents and our faculty were not using it. They felt it was too distant from them and was just being severely underused. And I feel like this is a story that I've seen multiple times in multiple institutions. So we went to the RISE program and we said, hey, you are an incredible resource. Can you come to us? And we kind of created this peer support training program. The idea was we brought them to our PGY4 conference curriculum, and they taught our senior residents how to be peer supporters and how to be emotional seniors. We integrated them into our conference curriculum, and we had the institutional resources that already existed. We didn't reinvent anything. We asked them, can we recalibrate this training for our senior residents? And they came with this kind of fundamental 7 principles that I wanted to talk about. The first one is showing up, right? Our residents took all of these. The idea of showing up is, as it sounds, just responding with all of your attention to whoever's in front of you when they are asking for peer support, right? Showing up, listening, just affirming the person in front of you. The second step that kind of the RISE model taught our residents that I am obviously kind of bringing into this space is the idea of being calm and staying calm. This speaks to 2 things. One, being a steady, non-anxious presence, but also 2, eliminating distractions. It was interesting, the RISE team to our residents, and I think about this a lot, really emphasized turn off your phone, find a private space, use the bathroom before you initiate a peer support session to be fully present. Kind of the third concept is this idea of listening, using reflective, open-ended listening rather than yes/no questions or closed questions, allowing the person to tell their story and sometimes even paraphrasing. So what I'm hearing is, right? Respond to the emotion, not just the content. The fourth kind of principle is this idea of empathizing, placing yourself in the position of the person in front of you. Using validating language, like many of us know, I can only imagine how hard this feels. Silence and presence can oftentimes communicate this empathy, sometimes better than words. Sometimes it's just sitting in the emotion. The fifth one that I have to sit and kind of repeat in my head all the time is avoid fixing, right? Our role in a lot of these peer support spaces is not to solve, not to correct the situation. It's simply being there. And sometimes it's to refer out. Maybe there is an employee assistance program. Maybe there's a mental health specialist. Maybe there's a risk management teammate that we need to reach out to. But the first stage is not to jump to that. It's really to just be in that space. 6, kind of on reflecting on this as a team, me, Amanda, and LA, maintaining confidentiality is so critical here. Keeping all encounters confidential. There's always the caveat that there's a clear risk of harm to self or others, right? Many of us are required reporters. Protect the person in front of you, but otherwise, in all other situations, be strictly kind of maintain confidentiality. And finally, the 7th step, I think, is one that many of us as peer supporters or as peer supporters in the future, we sometimes forget is the idea of activating a debrief. And this concept is focused on the idea that peer supporters need support as well. So if you feel like you just engaged in a very involved peer support session, activate a debrief with your mentors, with your peer supporters, so that you can both reflect on what worked and what didn't work, kind of garner lessons learned, but then also sustain a level of kind of self-preservation because there is tertiary trauma that can come from hearing a really difficult story. I want to pause here and kind of keep this on the screen. Which steps or which principles resonate with people? Which principles were unique or new to kind of to some of you guys?
The first 2, I think it's probably the easiest to do. You just show up, stay calm. Then you start listening, and then you start empathizing, which all we can do very easily. But then 5 is like, poop, like this is where we then all of a sudden like, yeah, or not just the fixing, but like, oh yeah, I did this too. And so it becomes like this struggle Olympics that like now you're comparing. So it actually you're taking away from supporting them and now they're supporting you because now you're talking about your own problem. And so like that happens a lot. And I see that a lot as well.
Yeah, and I love these principles because I think if you don't practice peer support yet, right, you know people maybe that do, and you're like, well, I couldn't do that. But I think once you see these simple principles, we already do that. We already listen and show up for our patients. But of course, we can listen and show up for people that are going through things and experiences we've maybe already had, as LA is pointing out. And the hardest part might be not bringing it back to, oh, I totally relate, which I know you can normalize to help, but I think just how simple these are really mystifies how can anyone do it? Yes. Any of us, if we want to, can help start to do this and be peer supporters.
Amanda, do
I
you want
love
to
it.
talk about that initiative that you did at Stanford? Because I think it hits several of this actually for any critical event that would happen in the department, but we focus on trauma deaths. Like and actually this is initiated by the trauma surgeons because they looked at it from a lens of moral injury, but we were like, I don't think this is like, it is about moral injury, but I think the bigger issue here is about like the vicarious trauma. Like you just ask well-trained people to do a resuscitation and then the patient just died. And then we just like move on. And we just go from like from this room and we just start seeing the next patients. And sometimes we get yelled at because they've been waiting for a long time and they don't need to know that we were in a resuscitation. So that was like the premise where I was like, Amanda, I think we can do work on this. So tell us what you did.
Yeah, and thank you. I think it's also important because I think we're so used to like the Rise or the Healing the Healers and the names of these great peer support programs that are existing at other institutions. But a lot of these, maybe what feel like simpler initiatives, are peer support in their own ways too. So I love that, LA. Thank you for bringing that up. It was as simple as that. We partnered with the trauma team, so the trauma and emergency department, looking at could we reach the teams that all experienced traumatic deaths, and could we have a four-pronged approach to approach them after one of these events. The first was we just asked people to pause for a moment of silence. So I'm sure a lot of us already practice that after a death, but that was our first. Let's pause for a moment of silence, honor the patient and the team for the work that's been done. The second approach we did was we asked for people, if I'm confusing step two and three, but we asked people to start having a what we called diffusing or emotional debrief for a 5 minute period or 10-minute period, but it's not as long as a clinical debrief typically. And anyone, but we asked the attendings to normalize this in the beginning, could do this. And it was just normalizing emotions, talking about the emotional part that got triggered after that, which is why we name it diffuse instead of the keeping it debrief to just have that little bit difference. The third was that an email would go out within 72 hours that you were part of this. We acknowledge that any death is hard, but especially these traumatic deaths. And the fourth was that we had this really great resource at Stanford called CARA, which was a group that is trained in helping in emotional debriefing, but psychologically safe Zoom that we created once a month. Anyone could show up. You didn't actually have to be in one of the deaths that went out throughout, that month, but it became a normalized session that anyone could show up and talk about some of those things or feelings they've been dealing with. So we kept it kind of simple of just more trying to acknowledge emotions after these, but I think we so frequently forget to have a systematic way to help ourselves in the really hard work we all do.
And even just with a pause, right? It gets to you show up, you stay calm, you listen, you allow people to talk about like what is coming up for them during that resuscitation, after that resuscitation, and then you empathize. And really, the whole point of it being a diffusion and not a debriefing is that we're not fixing. We're not fixing that, like, I wish the ultrasound was there. Like, no, like, it was really frustrating for me to be in this room because, like, it reminded me of this. And I love what Charmaine put in the chat. It's a culture, right? Where we may not even feel we have the time to push pause before moving into the next trauma or just the next whatever. And does the culture support the time it takes, even briefly, to be able to address this? And I can tell you, like with Amanda's like pilot, it worked. And people actually like, we do that. Our nurses ask for this. Can we debrief this? Can we just sit down and talk about what just happened there?
But it's so hard because, Charmaine, I think your point is so huge because, yeah, we've given people now, in my new institution, a badge to help take the steps of pausing for a moment of silence and having the words to have emotional diffusion. But often it is, people feel like they have to get to that next patient. They have to keep going. So they have these badges behind their, I'm Dr. So and so, I'm nurse, I'm whatever role. We've given them to everyone, but it's just so hard to use, even though I know everyone feels better that they have that, but the space is hard to create.
And I'll just add that, like, the key part for me, and that one of the wins for that initiative was that we do this already. Like, Kiro showed us that board earlier about, like, we ruminate, we think about this and the 7 steps, right? The whole point of diffusion is like you're seeing it differently versus I'm seeing it differently, and Kira is also seeing it another way. Can we all talk about it so that when we drive home, we are all aligned with what actually happened, and you can clarify whatever questions you have and not have to deal with the shoulda, coulda, woulda alone. And that for me has been the most powerful impact of that intervention.
Yeah, and I would say like, and I'm so grateful for this and for the space, and I appreciate because I think there are tangible ways to be able to implement some of these, right? And I think culture is a big piece, depending on our health systems, our hospitals, like where we at with that.
Yeah.
I've been in this field 30 years and I'm so grateful for where we are today versus where we were 30 years when I first entered in terms of highlighting these conversations. I would just say, like, Amanda, you talked about, like, I think it's sort of the both and. It's like in the moment, can we do the thing? And then also there's a follow-up, right? And the intentionality around the follow-up because maybe we're not getting to it or getting to everyone or getting to the depth of it, but then we're like connecting and saying, hey, you're a part of this thing. Like, we care, we see you, like, how, right? How can we? Because sometimes in the moment we can't, like, especially if we're in a trauma center and like we're just dealt with this, but then the next trauma's rolling in. Like, right? Like, how do, and then people take that home and like, what are they doing with all of this energy and how our families impacted and how, like, right? Like, there's all these like systems issues. And so I appreciate this like so much. And I also would say, like, for some of us, the 7 feel maybe more intuitive, or some of these feel more intuitive. And what are the opportunities to help people feel equipped to be able to do these things? Like, showing up and staying calm may not feel intuitive for some folks. And so, like, what are the opportunities to help more people feel equipped to be able to like hold space
Yeah.
and like be in these places for folks?
And I think one thing that you brought up is that we learned from that pilot was that some people process things differently. They can't talk about it actually immediately after a traumatic event, and they need that time to like sit with themselves. And then that's why within 72 hours was the one that was the magic spot that we learned from the grief counselors, that like that's when you actually, in fact, if I reach out to you immediately, you're going to be so triggered that you don't want to talk to me, but then just give you some space, walk it off, and then can we talk about it afterwards? That's what we do. Like, all right, we tell people in 30 minutes we're gonna have this diffusion. We're gonna meet in this room so that people can do whatever that they need to do.
Yeah. These debriefs and kind of engaging with each other, with the residents, the senior residents loved it because they felt like they were just a bit more empowered to keep on engaging. Similar, it seems like the feedback at Stanford with kind of the nursing teams, they like when we talked to our residents after doing this, they anchored on this. More peer support has improved the culture of wellness.
Yeah.
Exactly what you said, Charmaine. I think diffusing it a bit more, making it more of the culture allows people sometimes to do it in the moment, but sometimes it's a phone call at home and then systematically creating a 72 hours. Sometimes things are busy and sometimes later is
And
better
also
than
there's a
now.
lot of resources required for that. So I will just say that like the culture of support here that they're referring to, that culture of wellness is really the culture of support. But I would push this a little more, that what we're doing right now is like empowering people to be peer supporters and supporting each other. That's great. But I can also tell you that like from somebody who runs like an institution-wide peer support program, there's other perks that you can get beyond what probably you're able to do, which is our conversations are legally protected, confidential, and it's been vetted by lawyers. And so I can truly talk. And for the most part, like the details actually are not relevant. Most of it is just acknowledging the physiological changes that happens and the expected things that happen. Like you don't sleep well, you probably either eat a lot or you don't eat, and you're probably getting palpitations when you think of that room or when you're about to go into that room and all of those things. And like talking through that and figuring out what are you going to do next is going to be super helpful. And also knowing that is not discoverable. Like that, I think from an institution perspective, it's important that yes, we can all train to be peer supporters. And there's also a role for a formalized system to allow for this. That's why like I'm very impressed and grateful that Charmaine is here, because as a social worker, like we've piloted this in one of our departments in OBGYN, and that's exactly what they've utilized, right? Like having social workers as peer supporters, because number one, they're so comfortable with this. They know this, like, and this is their mojo. Like they do this all the time. They are experts in this. And can we, because sometimes we get into our heads that like, I can only talk to a doctor to do this. And yet there's a lot of other resources out there, especially experts like Charmaine, who actually can leverage this and bring it to another level without requiring, again, volunteer physicians to take the time to do this. There's certainly benefit for that, but I think there's a space for both.
I totally agree. We're engaging in such a beautiful discussion. All right, we're reaching time. We wanted to end and make a kind of very strong nod to kind of the overarching the overarching message of where we're sitting, right? This was a discussion about peer support, and thank you guys for being so engaged in the discussion. But what we're working against, right, is this tide of depression and suicidality that really hits us as healthcare providers. This is one big piece that we wanted to emphasize. Essentially, one of the first large national studies that really identified this, that we are incredibly at risk, physicians, of suicidality, far more than the working adult.
And that if we are having thoughts of suicide, we're less likely to seek help. That is actually like an even more important thing, that like, yes, we can train people to be peer supporters and we can support each other. But when we get to that point, it's like, I can't, like all of those things that happen, right? Then we disconnect and we're less likely to actually seek help.
This was the biggest surprise I reached, this 1 in 3 number. 1 in 15 physicians contemplate suicide annually. 1 in 3 of the ones who are most at risk, like Alay brought up, do not look for help, do not seek help. And this is kind of the critical point. These are the people who are sitting in their secondary stress or sitting in their kind of their duck syndrome or outside of the resilience zone, but are not pursuing help. We are very aware about burnout, but self-compassion, something that Ali and Amanda and Charmaine, you brought up multiple times throughout this conversation. Self-compassion in the study, self-valuation was showed to reduce suicidality. And that's kind of the message of this entire month, of having some level of self-compassion in mitigating this kind of idea of being alone. Thank you guys.
Self-compassion is being able to reach out and be connected with other people.
We are always here. All three of us obviously care so much about this. We want to be resources in any way. Robert, I'm reading your message right now. As a new PEM attending, you appreciate this space. We appreciate you being here. And we hope that, like, we've talked about many different models, but I think finding what works in your own space, if we can help in any way, that's our contact information right there.
Yeah. There's also, again, a ton of resources. Amanda, you went through the ASAP NAMI collaboration. Do you want to briefly talk about that?
Yes, if you are, and I know we're trying to make this more normalized throughout most of the emergency societies, but ASAP and NAMI, which is the National Alliance on Mental Illness, have created a great peer support training. I think they even do some of it virtually now if you want to find an off-cycle one that you can't make it to ASAP. It's a 4-hour course, it's CME. So not only are you doing what you need to be doing for your faculty and to keep up everything, but you get trained to be a peer supporter, to go through those 7 steps that we've talked about, to practice it and to feel more comfortable with it so that you can now be a supporter, whether nationally or at your own institution. So hopefully also what we've instilled is you don't have to do any of this alone. We are here to partner with you to help give you what resources we have or show you what we did so that we can just keep helping everyone help our colleagues and ourselves.
I'll add one more and then I'll give it to Kiro to end this, because this is really his baby. Our work is very hard. We have a very tough job, and we also deserve the care that we easily give to others. And so I hope that, be it peer support, whatever else resources that's available, I hope that we can take advantage of that, including just being aware that these resources exist. And really, truly, hat tip to Kiro. He developed, designs, all of the things that you saw in the slides. He worked really hard for this, and I'm really honored to have co-presented this with him. And thanks, Amanda and Kiro and Dawood as well for making sure the technology is working for us. Kiro, take it away.
Thank you guys for being here. Ali, Amanda, everyone else kind of here with us. As you see, right, we're a collaboration from coast to coast. And I think the idea here is peer support, obviously, most importantly, happens in the communities. But I think peer support and kind of mentorship and kind of the network of people who care about this is coast to coast. And I think that was my biggest learning point as I put together these slides with these amazing people. But I'm happy we could spend this time together. Thank you for being here 2 minutes afterwards. But of course, I think we all acknowledge this is an incredibly important topic. We really appreciate your time.
Thank you.
Thank
That's all
you.
we have. Have a great night, everyone.